So we're going to go into the panel discussion now. It's actually a curated panel discussion, so we're not opening Slido at the moment, but hopefully Xavier will have a glass of wine with us at the end and answer any questions you might want to target at him. I'd like to introduce to the stage Beryl Logie. So Beryl is the past president of the Melbourne Osteoporosis Support Group, and she's a passionate advocate for the prevention and treatment of osteoporosis. So both Beryl and her mother suffered from osteoporosis, and as a result of that, Beryl has been active, and given every opportunity, she will advocate for better fracture prevention services. So welcome, Beryl. You're very welcome to the Australia-New Zealand Hip Fracture Registry. Thank you for your time today. Also joining us is Dr. Nargis Shaheen. So Nargis is around somewhere? Hopefully. Oh, yes, lovely. So Nargis is a geriatrician working in the orthogeriatric setting at Concord Hospital in New South Wales. She's also at Macquarie University Hospital. So she's got a keen interest in the perioperative care of older people, and she happens to work at a hospital that's very good at getting people on treatment for osteoporosis before they're discharged home. So welcome, Nargis, as well. So I'm going to ask the first question of Beryl, and I'm guessing Beryl's had lots of opportunity to think about the answers to these questions, given that she is somebody who's out there advocating in public for better secondary fracture prevention. Beryl, what would you like to see in place for preventing hips and other fractures? So not just hip fractures, but what do we need to be doing?
Well, to prevent the secondary fracture, we really do need more fracture liaison services in Australia, particularly outside New South Wales. New South Wales is fairly well served with this. Queensland is getting there, but there doesn't seem to be very much elsewhere, particularly Victoria, where of course I'm most passionate about. And it's very worrying to see that there's not enough help out there for people when they present with a fracture. They're not followed up, and they're just sent home and nothing's said. So that's the biggest problem I feel in that regard. Also, the GPs need to perhaps keep their eye out more to their patients for risk factors that people have. It doesn't hurt to do an odd blood test to check calcium and vitamin D levels as a starting point. But there are several risk factors that the GPs should be aware of that they could look into with their patients to see if they qualify for a DEXA scan. And then, of course, that would tell the true story after the DEXA scan as to what was required of the treatment for the patient. I also worry about the various fitness groups in the community who are working with people. They don't always seem to understand the importance of osteoporosis. They don't understand osteoporosis. I've been in that situation with a fitness instructor. I had a letter from my doctor to say I had osteoporosis. I was attending these classes. After some time, another person arrived in the class, and this person was asked, "What is your health problem?" And the person said, "I've got osteoporosis." And the instructor said, "What's that?" So I didn't go back.
So Beryl, in front of you now is a very diverse audience of various health professionals. What can we do? How can we be better at getting that message out? Now, you're sitting next to an orthopaedic surgeon who, in fact, I need to be careful what I say here. In this country, on the whole, orthopaedic surgeons are not actively engaged in the secondary fracture prevention conversation. They are excellent at fixing the fracture, but they are a very powerful group to the public and the patients that they serve. How can we improve the orthopaedic message, getting the orthopaedic message out there that secondary fracture prevention or fracture prevention in general is really important?
Or perhaps the orthopaedic surgeons, before they, when they've treated the patient, mended the fracture, then talk to the patient about follow-up with their GP to see what their risk factors are for further fracturing. People who've reported, Healthy Bones Australia have remarked on this, that 55% of people who report with hip fractures are found to have had previous vertebral fractures, but they just thought they had a bad back.
Yeah.
It was more than that. And if that had been found, it might have prevented the hip fracture.
That's a very good point, and it's worth remembering that 50% of hip fracture patients have already had a low trauma fracture before they meet us with their hip fractures. So they're essentially a semi-elective procedure. They've told us they're coming, and we have failed to stop them from coming. Xavier, I wasn't actually picking on orthopaedic surgeons. I'm just trying to get the message. I was talking to Andreas at lunchtime as well, just trying to get that message across, that what you say to a patient in terms of how they're doing, etc., adding in a message about the importance of future bone health, I think is important, and I don't know that we're good at doing it or good enough at doing it. But so how does it compare in the UK?
So I think you're exactly right. The majority of patients that end up with a hip fracture, which is what we're all trying to prevent ultimately, have been through our clinics, and most of them will have a fracture that's treated non-operatively, so they won't have access to the MDT team that's working in secondary care. And they may not have met their GP for many, many years. And so when they come in with their wrist fracture or their vertebral fractures or their ankle fracture or whichever fracture it is, then that's a key time to intervene, clearly. And I think we all know that, but the question is how you do it. So the FLS system in the UK is maturing. It's probably 5 or 6 years up and running. And apart from Qasim Javed, who's a rheumatologist, all the people he's gathered around him to make it work in hospitals are orthopaedic surgeons. And so we listen to our colleagues at orthopaedic conferences talking about how do you prevent future fractures. And in hospital, I think the way we make it work in our fracture clinic, which is a pretty compressed environment, is the Royal Osteoporosis Society have got a great little leaflet which tells patients the 10 things that they should expect, the quality standards they should expect with a Herald fracture. And once they're armed with that information and told by their surgeon, go and get this sorted out with your GP, then they're actually quite good at seeing that through. Because you just sort of threaten them with a hip fracture. In 10 years' time, you'll be back here with a broken hip. And most people of that age know someone that's had a hip fracture. And I think most people find it to be, it'd be interesting to see what Beryl thinks, but most people are pretty scared of the possibility of getting a hip fracture, having seen someone experience it.
Beryl, do you want to respond to Xavier in terms of the approach in the UK?
No, I don't know a great deal about the system over there, except I do get the newsletters from the IOF, and it only emphasises the fact that there's fracture liaison services in 40 other countries around the world doing quite well, and what's happening here. And it's very frustrating, I can tell you. Also, a lot of GPs are reluctant. I found this within the support group. The members have said that their GPs have said, oh, there's nothing we can do much. And there's nothing a specialist can do that I can't do, which of course is not right. And these are the things that need to be brought home to people. That you've got to, the patient has to be proactive, because otherwise you don't get very far.
Elizabeth, did you want to add on to that? So you're out there listening to what the patients and consumers are are telling what their experience is like. Have you got messages for us from what you've learned by talking to consumers?
I think the two messages that I would share are orthopaedic surgeons have a very important place and a very powerful place in the patient's life as well. And so what orthopaedic surgeons say to the patient will carry weight. But the other thing that I would like to say is that it's also a shared responsibility. So it's not just the medical team, it's also physiotherapists in not just the hospital setting, but in the community setting, because Beryl and other people will seek primary care, not necessarily hospital care. So there's opportunities across all of our sectors for all of us to share the responsibility of awareness of osteoporosis, knowledge of the consequence of a fragility fracture, and advocating for better management along the way.
And of course, there are a number of challenges in Australia, not helped by our state Commonwealth divide, which often leads to competing interests. So, for example, when you're in some states where there is a particular agreement between the acute or state hospitals and the Commonwealth, the hospitals, acute hospitals, are not keen to fund the treatments for osteoporosis. They see it as a chronic disease and therefore the responsibility of GPs and essentially then the Commonwealth government through the PBS funding system. So there are competing priorities there. So for me, at the Prince of Wales, it's actually very difficult for me to prescribe Prolia. They're quite happy for me to prescribe a bisphosphonate because it's cheap. But Prolia comes at a bit more of a cost. They would much rather that I handed over that responsibility to the GP. But the reality is, as soon as that individual loses hospital, the chances of them getting on effective medications drops dramatically. So there are missed opportunities just by the very way that our health systems are set up. Now, that's not the same in every state. Those Commonwealth state agreements differ between the different states, but in New South Wales, we are not encouraged to prescribe particular drug like denosumab because of the cost, despite the fact that the cost of the fracture is borne by the acute hospital, but it's very difficult to manage that. Nargis, you are the envy of most of us. So at Concord Hospital, over 70% of patients with a hip fracture leave hospital having received treatment for osteoporosis. Now, you weren't always in that position, and I know Marcus is sitting there as well. This is a perfect example of how the data has driven the change. So Concord was down the bottom in the early stages of the registry. And I remember going to Concord and Marcus looking at this data and horrified. And you guys have turned things around, and now you are the top of the pops performer when it comes to secondary fracture prevention. What is it you have done?
So I think the credit goes to you as well, Jackie, because in my first week of taking over the orthogeriatrics, Jackie gave us a presentation where Professor Seibel and Dr. Delacroix, both of them are in the audience today, were there. We were horrified to see that we were bottom of the list for osteoporosis. And that's where we started the wheels in motion, and of course we could get nowhere for the Prolia. But we put up a business case for Zometa and high-dose vitamin D, along with endocrine orthopedic surgeons as well as pharmacy, Department of Concord Hospital, who all supported us. And with time, we became more experienced with Zometa. So far, we have been giving Zometa to most people with, who have good renal function. However, recently we did start off with Prolia, but I don't have much success as per you as well to get the Prolia on board. The other thing of note is if people, we have this system, if someone misses Zometa in hospital or they are not eligible to get Zometa, we do refer them to Minimal Trauma Fracture Clinic, which is managed by Professor Seibel, and they take it over to get the Prolia on board. So it's happened that within 3 months, most of our patients leaving the hospital with a minimal trauma, not just fracture nerve, but minimal trauma fracture, we are giving some sort, either bisphosphonates or Prolia.
And so the majority get IVA cluster before they leave the hospital?
Are getting getting Zometa. Recently, this year, I did start off with Prolia as well, but I'm not as successful with Prolia as I'm with Zometa.
Now, Nargis, you also saw, I'm not sure, I presume you saw the data this morning from the secondary fracture prevention sprint audit.
Sorry, I was late, but
I did
because of the flights.
So I'll give you an example of what we saw. So there's huge differences in the way New Zealand and Australia are managing vitamin D. What's your approach at Concord to vitamin D? Are you doing lots of levels? Are you just handing out a large tablet? Are you waiting for people to be vitamin D replete before you administer treatment?
Yes. So as soon as the patients come in with fracture nerve or minimal trauma fracture, we do add on actually vitamin D because that's the criteria for high dose vitamin D. They need to be vitamin D deficient, less than 50. So once the vitamin D levels are back, during that time till we get the vitamin D level, we do start them off with 2,000 units of vitamin D, which is allowed. And if they are vitamin D deficient, we give them 5 days of 50,000 units of high dose oral vitamin D. Mostly I have seen about 98% in 5 days are replete with vitamin D.
So you're repeating the vitamin D again?
That was the criteria for my high dose vitamin D. If they are replete, we don't we give them the bisphosphonates, but if they are vitamin D deficient, I have to give them 50,000 and make sure that they are vitamin D replete before we give them Zometa.
Okay. So there's a great example of how a hospital has used its data. So we shared the data, they saw the data, they used the data to drive a business case, and now more patients from Concord Hospital than any other hospital in this country at the moment are getting treatment for osteoporosis. So well done. I think we'll probably draw this to a conclusion. Thank all our panelists, and if I give them time to get down, we will then move on to the Golden Hip Awards. So thank you very much to our panelists.